Hi everyone, it's Dr. Campbell, and I am back with another ICD 10 CM Coding Guidelines review. Today, we are going to focus on Section 4. I think this is a section that's kind of tucked away and no one really knows that it's there, but it is there, and it is intended to be used by hospitals for reporting hospital-based outpatient procedures, and then it is also used by the professional, that's your physician or your nurse practitioner, just to name a few, and these guidelines are to be used regardless of what setting the professional actually sees the patient in. So that's inpatient, outpatient, surgery, nursing home, just to name a few. So these guidelines are to be used in addition to Section 1A, Section 1B, and Section 1C. All right, so let's jump right in with our first guideline. This guideline focuses on the first listed condition. In the outpatient setting, the term first listed is a term that you will hear instead of principal diagnoses. Of note, in determining the first listed diagnoses, the coding conventions, and we talked about those before, of the ICD-10 CM code set, as well as your general and disease-specific guidelines, they will actually take precedence over our outpatient guidelines. As many of you may know, in the physician office setting or the outpatient setting, the diagnoses may not be established right away. We might just have signs and symptoms because sometimes it takes a couple of visits for a final diagnosis to be confirmed. So one of the rules that's very important to remember is that when we're coding, we are always going to utilize both the alphabetical index and the tabular list to complete the coding process. In fact, we must verify our code in the tabular list, but we have to begin with the alphabetical index. So two guidelines related to selection of first listed diagnoses just to get us started. First up is our outpatient surgery. When a patient presents for outpatient surgery, also known as same-day surgery, you're going to code the reason for the surgery as your first listed diagnoses, even if the surgery is not performed due to a contraindication. So an example could be patient has cholecystitis and they're going to have a cholecystectomy. Anesthesia is administered and the procedure is begun. The patient goes into the blood pressure shoots up very high and the provider has decided to stop the procedure. Well, the fact still remains that the patient had cholecystitis and they were having the cholecystectomy, so you still want to list that diagnosis as your first listed diagnosis. As you know, codes are designed to paint a picture of the encounter. So in this particular example, if there was a contraindication, there's actually a Z code. We talked about Z codes in another video where you would list procedure not done due to whatever the contraindication was. And then if the patient experienced tachycardia, for example, that would be listed as your third code. But first listed code would still be your reason for the surgery. Observation stays. When a patient is admitted to observation, that's an outpatient service for a medical condition, that medical condition is to be listed as the first listed diagnoses. Now, in the case where a patient has outpatient surgery and they develop a complication that requires the admit to admission, again, observation is an outpatient service, you're going to code the reason for the surgery as the first listed diagnoses, followed by your complications as your secondary diagnoses. I always think about outpatient surgeries or just surgeries in general that your insurance payer requires us to pre-authorize, pre-approve, get those services pre-approved. So they know that the surgery was pre-approved for what condition. So the surgery is what happened, the diagnosis is why it happened, and so when the claim comes in, they're expecting to see that diagnosis because that was what was pre-approved. However, when those situations occur, when the surgery does not take place for whatever reason, those codes again paint the picture as to why it didn't happen. All right, next up, Guideline B, codes from A00.0 through T88.9 and Z00 through Z79. These codes can be used to identify the diagnoses, the symptoms, the conditions, the problems, complaints, or other reasons for the encounter or visit. So any of these codes in this particular range can be used. Guideline C, accurate reporting of our diagnosis codes. As always, guys, the documentation should describe and support the patient's condition using terminology that includes the actual diagnoses that the patient has, as well as symptoms or problems or other reasons for the encounter, as there are ICD-10 codes available to describe these different conditions. Next up, codes that describe signs and symptoms. So, per guidelines, codes that describe signs and symptoms as opposed to diagnoses are acceptable for reporting purposes when the diagnosis has not been confirmed by the provider. So, as I mentioned at the beginning, it may take a couple of encounters for the provider to actually confirm what the diagnosis is. And so we may only have signs and symptoms available to us. In our previous video, we actually went over signs and symptoms. They are found in Chapter 18 of our code set. We also discussed that Chapter 18 includes some, but not all, of our signs and symptoms. All right, Guideline E, encounters for circumstances other than a disease or injury. So not all patients come to see their physician or provider because they're sick. And in those instances, we have code family Z00 through Z99, and those codes are provided to deal with occasions when the patient is not sick. Next up, Guideline F, level of detail in coding. Guys, this guideline is all about us always coding to the highest level of specificity. So how do we do that? Well, number one, we always follow correct coding processes. So we begin in the alphabetical index, we verify our code in the tabular lists, we are led and guided by our instructional notes. In the tabular list, you will know if an additional character is required for that code because it'll say something like a little symbol, check fourth digit, check fifth digit, check sixth digit, or it might say a seventh character extension required. In either case, the rules state we must code to the highest level of specificity for a given code category. Next up, we have Guideline G. Here, we're talking about the reason for the encounter or visit. We are going to list that code that describes the diagnosis, the condition, problem, or other reason that is supported by medical record documentation that's responsible for the services that are being provided today. I always say my claim form is going to demonstrate what happened, that's my procedure code, and why it happened, that's my diagnosis code. That is what establishes medical necessity for a service. Additionally, we can also report any additional codes that describe any coexisting conditions. And in some cases, the first listed diagnoses may be a symptom, but guys, remember, if the provider is not able to confirm the diagnoses, we must go with the sign or symptom. Next guideline, uncertain diagnoses. Here's the rule that you're going to say, wait a minute, I recall reading about uncertain diagnoses in another portion of the guidelines. Well, remember, we're talking about outpatient. In the outpatient setting, when we're coding for the provider or the outpatient hospital, we do not code uncertain diagnoses. Instead, we are to code the condition to the highest level of specificity for that encounter or visit. And again, guys, this could be signs, symptoms, or abnormal test results. All right, next up, chronic conditions. Chronic conditions can be coded and reported, and this is what's key, as many times as the patient receives treatment and care for that condition. If the condition was previously treated and no longer exists, this is when you can use a code from our history of codes, which happen to be Z codes, and they are found in category Z80 through Z87. Of note, we only report those codes if the historical condition or a family history of a condition has an impact on the care that is being provided today. Guideline J, conditions that coexist. We are able to code all documented conditions that exist at the time of an encounter or visit that impact or require patient treatment or management during that encounter. Again, we do not code conditions that were previously treated and are no longer present. Guideline K. This is our guideline for encounters when patients come in for diagnostic services only. In these particular situations, you are going to sequence first the diagnosis, condition, problem, or other reason for the encounter or visit that is in the medical record that is shown to be chiefly responsible for today's encounter. Of note, codes for other diagnoses, such as your chronic conditions, of course, can be sequenced as additional diagnoses. Now, in those situations where you have a routine laboratory or radiology testing service that's being provided and there are no signs, symptoms, or associated diagnoses, we have code family Z01.89, which is other specified special examinations that can be used. If you have a situation where routine testing is performed on the same day as another test to evaluate a specific sign or symptom, it is appropriate to go ahead and report both the Z code and the code describing the reason for the non-routine test. Guys, go back to what I said. Your coding tells what happened and why. So if you have a routine test, why? Non-routine tests, why? Again, it's the coder's responsibility to capture the codes that support the services that are being provided on today. All right, couple more things. For outpatient encounters, for the diagnostic tests, where you actually have the test results at the time of coding, coders that are coding outpatient or coding for the provider can code any confirmed or definitive diagnoses that are documented in the interpretation and report. Any signs and symptoms are not coded as an additional diagnosis. Now, this does differ from inpatient coding where we cannot code abnormal findings on test results. Next up, we have Guideline L, therapeutic services. Now, therapeutic services, therapeutic means therapy. So when a patient is arriving for therapeutic services, we are going to sequence first the diagnosis, condition, problem, or other reason for the encounter that is supported by the medical record. And of course, if the patient has any chronic conditions, those can be sequenced as additional diagnoses. There is an exception to this rule. This exception pertains to when the primary reason for the encounter is chemotherapy or radiation therapy. In this situation, the appropriate Z code for chemotherapy or radiation therapy, those are actually sequenced first, and then the diagnosis is sequenced second. So if you have a patient that's coming in for chemotherapy because they have breast cancer, you're going to use a Z code, which is not a procedure code, a Z code that says encounter for chemotherapy, and then you're going to list the cancer as your secondary code. Next up, we have guideline M for pre-op evaluations only. Remember, the codes paint a picture. So when a patient is coming in for a pre-op eval only, we are going to sequence first a code from category Z01.81, which is encounter for pre-procedural examinations to describe the pre-op consultation. Then you're going to assign a code for the condition to describe the reason for the surgery. Makes sense. Patient is coming in for a pre-op visit for XYZ problem, which is subsequently what's going to be the focus of the surgery. If there are any findings related to the pre-op evaluation, you can code those as well. Next up, we have guideline N for ambulatory surgery, and I know you're thinking, first listed is going to be the reason for the surgery. Well, kind of, sort of. Here are the rules. If the postoperative diagnosis is different from the preoperative diagnosis and the diagnosis post-op is confirmed available to you at the time of coding, you're going to select the post-op diagnosis because it is the most definitive. Guideline O, related to prenatal visits. In another video, actually chapter 15, we went over the guidelines for routine outpatient prenatal visits. Guideline P, encounters for general medical examinations with abnormal findings. So we do have subcategory codes Z00.0 and Z00.12. And these are for your adult and your routine child health examination. And within these code families, we actually have two options. It's without abnormal findings and with abnormal findings. And what we're talking about here is with abnormal findings. So should the exam result in an abnormal finding, you want to make sure that the Z code shows with abnormal findings. Additionally, you are going to list a secondary code for the abnormal findings. So abnormal findings refer to a condition or a diagnosis that is newly identified, or it could be a change in severity of a chronic condition, such as a patient that previously had controlled hypertension and it's uncontrolled now, or a patient that has COPD and today they have an exacerbation of the COPD. Last guideline for factors influencing health statuses with the focus on screening. We do have guidelines for that. We've actually covered that in another video on chapter 21, which are the Z codes. Those are your factors influencing health status. Well, guys, this has been the end of our ICD-10 CM Coding Guidelines review, because we now have officially made it through all 4 sections. Guys, thank you so much for listening. Please be sure to subscribe to our YouTube channel. Have a great day.